What we knew for sure was that patients die while they're waiting. There's research that supports that.
There are things that are good and there are things that are good enough, especially in times when we're talking about healthcare resource limitations.
With this Pearls paper in any crisis, wanted to ensure that patients would always be able to be seen and treated.
This has really helped by making sure that we're doing the right tests at the right time on the right patients.
When it comes to cardiovascular care on the organizational level, MedAxiom understands the challenges your program is facing. Welcome to MedAxiom HeartTalk, the podcast where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
I'm Melanie Lawson, a journalist in Jacksonville, Florida, and host of MedAxiom HeartTalk. Today, we are diving into the Pearls paper for part 2 of this series. In case you missed our last episode, Pearls stands for Planning, Efficient, and Resource Leveraging Systems. It's those pearls or best practices that might be just what your team needs during a crisis. Today's guests are part of the team of 13 distinguished authors who contributed their expertise to the Pearls paper. We will focus on their various geographical perspectives. First up, joining us is Dr. Elizabeth Perpetua, founder of Empath Health Services and faculty at University of Washington in Seattle. She led the Pearls paper and the first published study describing the structural heart coordinator role and coordination in the United States. Next, joining us from Atlanta, Dr. Patricia Keegan is the original coordinator and nurse practitioner at Emory Healthcare with the partner trial, now the director of strategic and programmatic initiatives across all of Emory Heart and vascular system wide. Roseanne Palmer is in New Hampshire. She is the original coordinator and nurse leader at Dartmouth Hitchcock with the partner trial, now the program manager for structural heart. Roseanne has worked with the Red Cross on crisis management projects. She is a national expert on shared decision-making. And last but not least, Susan Schnell is in New York City. She is the original coordinator and nurse practitioner for the structural heart program at Columbia University Irving Medical Center at the time when TAVR was in the first in-man experience back in 2007. Revival trial preceded the partner trial. Susan is currently the Chief Operations Officer for Columbia Heart Source, supporting cardiovascular program development and quality for hospitals in the United States and abroad. Lots to say about these impressive experts in their field. So we do encourage everyone to read their full bios in the episode notes, but now we will welcome them to the podcast. Dr. Elizabeth Perpetua, Dr. Patricia Keegan, Roseanne Palmer, and Susan Schnell. Welcome, welcome.
Thank you, Melanie.
Thank you.
Thank you so much.
Thank you. Glad to be here.
Yeah, and we're so glad that you're with us today. Well, this will be a robust talk, so let's get the party started. My first question that I love to ask all Heart Talk guests, because it really lets us dive into really your motivations and a little more of who you are. But why did you decide to get into healthcare? And did you ever have that aha moment where you knew you were in the right place? And Dr. Keegan, I'll start with you.
So mine was because of TV. So back in the 70s, there was a show called Emergency. So the predecessor of Grey's Anatomy or even ER. And there was a nurse on that show. Her name was Dixie. And she kind of controlled how the hospital went and, you know, just really a strong patient advocate. And I knew that I was supposed to be her someday. And so definitely living my dream by becoming a nurse and being able to work with patients and this amazing group of colleagues.
I love that. I love that. All of us wished for that, but not all of us made it. So congratulations. All right, Roseanne, what about you?
Sure. I have a little bit less altruistic reason for actually choosing nursing. Initially, I just needed a way to support my family. I had 2 small children at the time, and I needed a career that I knew that would last me a lifetime and would put food on the table for them. But it wasn't really very long after I began as a nursing student that I realized that I was drawn to nursing because I needed something meaningful in my career. And I realized very quickly that the career loved me back just as much as I loved it. And it grew with me and became even more meaningful as I grew into my own skin.
Roseanne, that's actually altruistic because you did it for your family, and then, like you said, you were right where you needed to be. Susan, what about you?
Well, my grandmother was a nurse, and actually, she tried to talk me out of being a nurse at the time. But I had a childhood illness that I was in and out of the hospital, and I realized, with the nurses caring for me, it was their presence and their support. And I realized one day, like, this is what I want to do. So, against my grandmother's best wishes initially, and then she was very proud when I became a nurse.
I'm sure she was. So many of our Heart Talk guests do have that personal story, and you just make it happen. And Dr. Perpetua, we have had you on before. So for listeners who might not have caught you on our last episode, how about you? Remind us of that aha moment.
Sure. Yeah, I am first generation Filipina American and second generation nurse. My mom is a nurse. And so I grew up really going with her to work. And also when I was very young, my father, he had a heart attack at age 38. And it was at a time when they couldn't open up that artery. And I remember just hearing that there weren't great options except for him to complete his heart attack. And so really, I just had always been in love with the heart from that time, thinking about early coronary artery disease in my culture, and then wanting to pursue options. And that led me to cardiology because of innovation.
Wow. Oh, I love that. I loved you back for sure as well. All right, Dr. Perpetua, let's keep you talking. Our healthcare system is facing a significant supply chain problem. We're seeing that in a lot of different industries. 97% of MedAxiom member organizations surveyed say they are aware of a potential shortage of iodinated contrast. The majority of respondents report keeping only 15 days or less of contrast inventory in stock. If you do want to see the full survey results on this one, listeners can go to medaxiom.com/reports. So my question is the Pearls paper meant to help CV programs mitigate challenges like these? If so, where should they start?
Oh, that's such a great question, Melanie, and so timely. Just starting with the beginning of the Pearls paper, it's public health principles, it's principles around resource allocation and how we can use triage, surveillance, and care pathways so that no matter what the constraining issue is, we can have a way to handle it systematically. So what that means is, in the beginning of the pandemic, like in Seattle, where we had the first case, we didn't know what we were really going to need, but we knew space and PPE were the issue. And as these waves have come through, right now we're seeing critical staffing shortages. Now we see this kind of supply chain, impact where contrast is the issue. And it still is number one about the patients and what they need, right? And how we can ensure their safety and their quality and make sure that there's a shared language that the teams are using in order to say who needs to be, treated right away based on how sick they are or what their symptoms are, and also what kind of resources they're going to need, including contrast. Right now, I'm working with sites where those transcatheter aortic valve replacement or TAVR procedures are being delayed, or other procedures where you might use more contrast, like if you might do that procedure with a coronary intervention at the same time. Those are kind of the considerations that people are making now, adding these Pearls principles to how do we apply this in this, contrast shortage. I think Roseanne, Sue, and Tricia, I'm sure have some examples of that.
Yeah. Any other takes on this? Because I know that you're all experiencing this in different ways.
So I shared with Liz and Roseanne yesterday, reaching out to one of the very well-known interventional cardiologists who is on many of the guideline papers and everything. And I said, what are we doing? And his response was use less. And it really hits home where we think about when people aren't being necessarily proactive or looking at that forecasting or being set in a way that we can make a more meaningful plan to help, again, mitigate these supply chain issues. And I responded to him and I said, use less, that's not really the correct answer. And he, it really just showed that we have to be a little bit more diligent and prepared to share what we can with other sites in how to utilize things, not do redundant procedures, not do repeat testing or scanning just because we think our CAT scans are better than someone else's. We really must be thoughtful and think about, preventing overuse of things.
That takes a lot of coordination too.
Yeah, exactly. It takes a lot of coordination, and it also takes some self-reflection, because we all work at various healthcare systems, and we want to provide the best care for the patient, whether it's in structural heart, whether it's doing a CT angiogram for other reasons, and we reflect that we believe that our testing might be of a certain caliber. We have a higher level of imaging availability, and we want to provide those patients with those higher levels of care. But we have to reflect upon that. There's sometimes, there are things that are good and there are things that are good enough, especially in times when we're talking about really, healthcare resource limitations.
Anyone else want to comment on that?
Yeah, thank you, Melanie, for asking that question. It's so timely. I think for me, the thing that struck me first was that I'm so glad that in the Pearls paper, we chose to include patient voice in decision making during these really hard times, because always the idea is put a mandate out from our organization to say slow this down or shut down these tests or these procedures. But we were able to, from our experience, not only with writing the paper, but our experience throughout COVID, be able to bring back that patient voice back in, to be able to think through which patients maybe do not want to wait, which patients perhaps want to go to a center that does have the contrast that's needed, or what patient might choose a different path. So for me personally, that was one of the biggest benefits, is to be able to bring that voice in and not make it just a governmental or political mandate, but really a truly heart team, thoughtful process for the patient.
Such a wonderful point. And I know your patients would appreciate that, because a lot of times they aren't heard. They just listen and go with the first suggestion. So to bring them into that equation as a partner is really, really important. Dr. Keegan, let me ask this one for you. In a TCT MD interview describing your team's nurse-led sedation and minimalist approach for TAVR and Emory, you emphasized the importance of specialized care protocols. How did your experience inform the care protocols in the Pearls project?
So for us, as we just talked about that, our contrast and having a national shortage of Omnipaque and VisiPaque, being able to use this process and really highlight who needs to have appropriate testing and what does that look like, really helped move our patients forward to the point where I don't know that we are on a pathway that we do have to limit patients because of contrast, because we've really delved down into who is the right patient for the right test.
I love that. That's a great example. Roseanne, let me bring you in again. Your expertise in structural heart is also extensive, especially relevant to today's topic. So you worked with the Red Cross on crisis management. I mean, Red Cross, every time they walk out the door, there's a crisis. I mean, they're always in that urgency mode. So what are some of the issues your teams witnessed in the Northeast, and how did your expertise inform your perspective on the Pearls paper?
Yeah, thank you for that question. The things that I learned, I think that most out of the Red Cross were three really essential things. One, you're not in this alone. Two, there's there are elements that you need to address immediately. There's that certain urgency right off the bat when a crisis is hitting you, but then there's also the long-term outlook that you need to plan for. So for example, when there was a fire in the Red Cross, you can't just put out the fire and walk away. There's all the sequelae that last for weeks and months and maybe even years. And it's similar as we're facing these crises in healthcare, that we can't just look at this minute with the contrast issue as an example, but how do we then look forward to prevent the next and the next and the next? The third thing that I learned during those Red Cross crises was that there's always a bright star somewhere in the midst of it, and there's certainly learning that we can take from it. For us in the Northeast, when the crisis first started, our location in perspective to both Boston and New York put us at this sort of highlight and fear that we would be taking some of those patients. So we geared up for that, and very early on we limited cases and we stopped bringing patients in just because of so many unknowns. But what we knew for sure was that patients die while they're waiting. There's research that supports that, and we certainly had experience around that ourselves. And so we quickly put into place, my first thing I did was call my colleagues here on the call today, as well as the other authors. And, that theory of we're not in this alone, I reached out to them and said, what are you all doing? What's your experience in your part of the country? And how are you thinking about this? How are you managing the patients that we're so worried about on our wait list? And that's how we sort of began to think about the Pearls paper. And so there's been one crisis after the next since the pandemic has started, and it has just really highlighted the need to have philosophical systems such as the Pearls dynamic to be able to come to the table with a plan, as Dr. Keegan described, a real plan where you take out the emotion and you have data and fact that support the decisions that you're making.
Mm-hmm. Just gives me a few chills listening to that. It takes me back a couple years, but my goodness, it was good that you had each other, and then you've created something that will help so many other people. And I think the MedAxiom community is just so cool because it offers that, to the members as well as the Pearls paper. Susan, let's hear from you now. Given your experience with system-wide healthcare quality improvement, let's talk about this big picture. How can this work that you all are doing, this in structural heart, how can that apply to improving patient care across the entire organization or health system?
Melanie, great question. And I do want to just address one of the things Roseanne mentioned, because we all experience, obviously, staffing challenges. And when we think of the big picture, some of the affiliates that I work with, one in upstate New York, had actually already had over a 32% reduction in their nursing staffing prior to the pandemic itself. And they ultimately operated a hospital with over a 46% reduction in their nursing staff, forcing them to close almost 180 beds.
Wow.
So we think about the way that obviously COVID impacted staffing, but we have to remember that there was a baseline to a challenged healthcare system. And that's why, Pearls was not only very relevant for what we faced with COVID, but it can be applied at any given time for multiple different disease processes. I mean, really, when we think about the bigger picture and healthcare quality across institutions and health facilities, there's really a beauty in best practice. The beauty in best practice about aligning processes of care, and really that is what Pearls is all about. The foundation, triage, forecast, surveillance, and resource leveraging can be applied through not only clinical care, strategic initiatives, multiple disease processes, and their related associated programs. Something that impacted the New York Presbyterian system, Columbia University Irving Medical Center, was the realigning of services across their multiple hospitals. And what I mean by that is they really leveraged resources. So if you want to refer to mothership, hub and spoke. There was a utilization of the higher level of care located at the main campus for the sickest of patients. And when I say in this case, it was really like the sickest of the COVID patients, because Columbia turned into an entire ICU facility. They had two types of services, ICU and palliative hospice care. So there were very limited numbers of other procedures being done, if at all. All facilities I know tried to provide the highest level of care to assure quality during this very dynamic time of great unknowns. You know, and these decisions were clinically driven, right? You've heard us all say to provide the right care at the right time to the right patient.
Right.
And that's really, you know, what Pearls is about. And I think that healthcare systems have to be responsible and ask themselves, how can they best prepare our teams to maintain these internal programs such during these times of great constraints? And Pearls can be readily adapted to provide guidance in these non-clinical facing roles as well. I think it's very easily modifiable and adaptable to other quality areas.
I know that anyone listening who has not read Pearls, or they haven't looked at it yet, they are anxious to look, because this is it's great information and a great resource for everyone. All right, well, we are going to take a quick break and we'll be right back. We want to give you more information on how you can take an even deeper dive into today's topic. You can find the Pearls paper on the TCT-MD website. There's a video library walking you through the key highlights of various sections of the paper. Go to tctmd.com/pearls. Also, check out the episode notes for bonus links. Welcome back. So far, we've talked about the challenges our guests experienced in different parts of the United States during the pandemic and how these moved them to craft the Pearls paper. So now let's look at the future. Let's go to Dr. Perpetua first. How can HeartTalk listeners leverage the Pearls paper? What are some practical steps to actually implementing these guidelines and care pathways into their own CV programs?
Sure. Thanks, Melanie. You know, I think I want to reference a comment that Sue had made earlier, which often any of us in any organization might hear in times of, you know, need, which is use less, right? For a long time, we've had this new math of being able to do more and more with less and less, but it really has been up to, you know, these nurses, nurse practitioners, physicians assistants, you know, big teams, techs, really this entire front line who is implementing a very vague, right? Use less. So usually what I say is, you know, let's start with being able to understand what are we doing now for something in particular. Maybe it's for how we are evaluating the patient and what that means for staffing and for the resources or treating the patient. And let's start there and start a conversation and bring this paper, like, you know, Sue and Roseanne and Tricia have said, bring this paper to that conversation with these key stakeholders and say, what are we doing now and what do we want to be doing to meet these goals? And a lot of heart teams have meetings, like has been mentioned. Sue, Tricia, Roseanne have mentioned these heart team meetings where you already have a lot of those stakeholders in place and can start having that dialogue and start referencing those consequences, like Roseanne has said. You know, I mean, I can still remember every patient that didn't make it to the procedure because they died waiting. And we, with this Pearls paper in any crisis, wanted to ensure that patients would always be able to be seen and treated. You know, I think I mentioned this in the last podcast. Change really happens, you know, peer-to-peer or in one-on-one conversations first, just like this. So we understand what our worlds look like and we understand where we want to go together, because we got to change those hearts first before we change those minds. And then if we have a language for it and they see the paper in, you know, this conversation, and then they can kind of take it with them and process and digest and then have another conversation. And then we get to hold each other accountable to where we want to go. But just starts with getting around the table and having a talk. Can't just be emailed,
Right.
like, I emailed that to you. That's good.
No, I know, because half the people don't see it. So those conversations, being intentional about it, and then you actually are forced to communicate and be engaged too.
Yeah. So those times when you're really, face to face, or in a, sort of, you have some digital intimacy, like a Zoom room like this, and we're able to just talk with each other like people and understand where we want to go and where we are now and how to get there.
Right. Sue, what are your thoughts on this? How do you make it practical?
Melanie, that's a great question. And I feel like you were just reading my mind, because as Liz was speaking, practical is something that I have to work with many sites on a daily basis. And I look at, pearls as the future is now. And taking a pandemic out of the equation, I still work with locations that don't have stakeholders at a table, that individuals aren't meeting. So I'm using pearls in the most practical sense as possible, as getting the foundation in place in institutions that have not yet even made that foundation or that first step. And from that, they can look at it, and it impacts their throughput, their pathways, their patient efficiency, patient satisfaction, because many sites do not necessarily even have the tools or the support from the stakeholders that should be at that table to even operationalize any of this.
Sometimes you need that starting point. And this is something to physically put down on the table and say, let's unpack this and see how we can be better.
Exactly. And I've shared the publication as that roadmap. Roseanne also knows that we still have challenges, with getting across shared decision making, and having to highlight how that's different from consent. So we have what we talk about the future, but the future is right now, because we need to still get the foundation in place in many, many, many locations.
Yeah, Roseanne, let me ask you that, because making it practical also does force people to lift up their voices. Sometimes you could say, hey, let's use this. Here it is right here. And then no one's listening. I mean, I think that's probably one of the first practical steps, is to actually get people to listen.
Absolutely. You're so right about that. In my experience, when there's a resource issue, or, a certain population is marginalized as a result of it, the problem then becomes everyone has skin in the game, so to speak, and you want to protect your patients. And so the general sense is, well, my patients are more important than yours, or sicker than yours, or it's more urgent than yours. And so people tend to hold on to their resource and their knowledge and what they can actually offer at the table. But to have something in place that's a strategic plan like this, that takes the emotion out, is incredibly important, because it's blessed by people in the industry that have been there and understand and have studied these situations and are offering out a solution. But unless you have all of the right people at the table from all of the divisions and departments that are affected by whatever the crisis might be, to be able to put in their thoughts and guidance and their knowledge of their particular dynamic in the healthcare system, then that's the only way we're really going to come together for long-term solutions. But by having this foundation, as I mentioned, to be able to take the emotion and the drama out of what's happening and look at it with clear vision and where we're all going in the same direction.
Dr. Keegan, let me pose the same question to you. And we talk about the drama. I know initially you said you were motivated by some of those medical dramas, and it was always about the emotion. So I think that's a hard thing. Like you're saying, you're like, some people feel like you're literally fighting for your patient's life, but everybody at that table probably feels the same way.
Oh, absolutely. And to echo my colleagues here, the challenge is the language is not banal. What we call low risk, does everybody call it low risk? And so we saw this a lot in our initial conversations, because the hospital would come out and say, well, you can only do high risk patients. Well, what does high risk mean? And is that a high surgical risk patient? Is that a patient at high risk for decompensation? Is that a patient who feels so sick that they're going to be hospitalized? Is it a patient who's hospitalized? And so I think, one of the items about this paper is really putting everybody on that same footing so that, you feel empowered to have these conversations and to be able to address these concerns that my colleagues have brought up. So again, from that standpoint, I think from reading through these type of papers and why we needed to kind of really create this, it's to be able to empower each other, and people who read this paper to be able to have those conversations, to advocate for their patients, for their staff, and for the organization.
Mhm. So much of this conversation has been patient-centered, and that's really what the Pearls paper was intended for. So let me pose this one to all of you. Can you share a story of how a patient has benefited from this work? Real life experience where maybe someone may be alive today because of the information that you were able to share.
I'll take that, Melanie. I think, for me, as you asked the question, 100 faces flash before my mind, and I hear the voices of so many patients that, we spoke with over the phone when we were having to postpone or delay their care, and their moral distress over those conversations. So I think of every one of them as the person that probably benefited, but more so I think about the people I haven't even met yet, because they're the ones that have something in place that we don't have to go back to the drawing board and figure it out necessarily. There's already something in place. And so I'm hopeful that all of those patients that are on my new referral list, that as we're talking today, those calls are coming in, and I feel like those are the patients that I'm hopeful will have benefited from this work.
I love that. Dr. Perpetua, what are your thoughts?
Oh, I think that beat where there was just that moment of silence, honestly, we were all there, I'm sure, where Roseanne was, just flashing on the hundreds, thousands, right, of patients who have touched our lives, have touched our, hospital systems. And one of the patients that, actually is still in my life because of these, our relationship and these principles being applied. I serve actually as, a care advocate, for him because of his complex, care and needs. And it just means something when somebody really knows, in that sacred space between a clinician and a patient, like, their goals, their history, what they've been through. And that creates so much, trust and confidence that, you wish that every patient could have in every encounter they have with healthcare. And I'm emotional thinking about him. And I think all of us can think of a patient who has really benefited from the kind of care that many of us have been doing since the beginning, how it's evolved since. And even looking forward, those concentric rings of change and impact that happen because of just listening really to the patient themselves, what they have as their goals and their values and their preferences, and starting there when we think about risk stratification and triage and surveillance.
Yeah, every time you all speak, I feel your passion. So that is one lucky patient, I'll just say, have access like that. Sue, what are your thoughts? Do you have anybody that you think of firsthand?
So, so many people like flash through my mind, just like everyone else. But honestly, where my heart really settled was two patients that I actually did not have any direct care of. I left Columbia briefly to open a program in my community that was 12 miles from my house. It was a bit of a struggle for me. It was a very different environment, and it was a lot of work. And I could have used Pearls back then, trying to leverage the resources that were me, myself, and I. And I belonged to a local marina. and we're sitting down at the marina and meeting all the new people. And out of a group of 25 people who are there for this, welcome to the marina party, 2 of them both had TAVRs at the program that I opened in the community. And to see them, one's a fishing captain and he's 72 and he's still taking out charter fishermen.
Yes, awesome.
And the other one has, like 7+ grandchildren, and he and his wife are like the social committee at this marina. And that touched me because of the expansion or the rings, like Liz just mentioned. It wasn't just where I started. It's grown and grassroots and now in smaller communities without large academic facilities. So I think they really stick in my mind the most.
I love it. I'm glad you met them and you were able to talk to them. Yeah.
And now they're good friends. We tailgate, and it's fun.
Oh, I love that. That was exactly how it should have been. Serendipitous. Thank you. That was good. All right, Dr. Keegan, you're up. Who do you think of?
Well, I think to Roseanne's point, there's a lot of people I think of. With having clarified processes, you don't have to reinvent the wheel with every single patient, because when a patient comes in, you don't want to be thinking about, okay, do I have the staff? Do I have the device? Are we going to be able to get somebody into the hospital? Are we going to have bed availability? So that we can concentrate on some of the other questions. And so having these policies and procedures in place and just clarified pathways so that I knew that our team was speaking the same language. Basically, any patient who has had a procedure in the past 2 years has been a beneficiary of these processes. And so again, for me, when I get to see patients in follow-up clinics at 30 days or 1 year, and some of these patients now I've seen 2 years out, and to see that they're thriving and they're doing well, for me, that's really just amazing. That not only from a procedural standpoint that we have these procedures to replace a heart valve without open heart surgery, but then also that we were able to work together to look at programs using the knowledge from New York, Washington, New Hampshire, among other places, to be able to benefit patients in Atlanta and the outlying areas.
Yeah, don't make the same mistakes twice, right? Let's learn from each other. All right, Dr. Perpetua, the Pearls paper concludes by saying it is ultimately people who transform care. With 13 amazing contributing authors, I can see that the Pearls Project embodies this idea completely. I mean, everyone's opinion is valued and everyone was able to contribute in a real way. So what advice would you give to CV thought leaders on how to best rally people around this shared mission of transforming care?
Thank you, Melanie. I think that the themes have been heard throughout our time dialoguing, and it first, starts with the patient. So we always rally right around the patient and what those needs are, and then being able to understand that better and communicate it better, because there's now a clearer pathway, a way to go forward, not just for right now, but looking toward the future. So that rallying cry really being around the patients, but our teams. We have this quintuple aim now, right? And that's where we rally around. It's about our outcomes of quality. It's about our experience, patients and teams, the staff. It's about the cost effectiveness of that care, so the resource allocation. And then it's also about now access. And we can't see and treat all the patients that need this care, or delay the kind of consequences, or prevent the kind of consequences Roseanne was saying we're seeing, when people were delayed getting the care they needed, without thinking about the future. And so really it is getting people together based on these shared values and starting that in a very, structured way, but dialoguing on it, because truly the people who are providing that care at all levels and involved in that care and also receiving that care have to be at the table. Unless care transformation includes everybody that is delivering the care and receiving the care in some shape or form, that there's representation, we miss every time, or we have a false start, or we're not looking future forward enough. And so that's also what we hope, even just in the authorship that we're embodying, right? We have a whole team. No one of us, right, can do this alone. And no one of us is as strong or as empowered as all of us. And that is what we really, truly hope people hear when they think about care transformation, and when we think about how we can use the Pearls paper going forward.
Yeah, and then you're ready for what's next. And I mean, to me, it sounds like it's a conversation that just never stops. We don't know what's next. So thank you. Thank you all so much for your time. This was a really, really wonderful conversation. Dr. Elizabeth Perpetua, Dr. Patricia Keegan, Roseanne Palmer, Susan Schnell, thank you so much for sharing your time, your beautiful stories, and of course, your expertise today on MedAxiom HeartTalk. Thank you.
Thank you.
Thank you
Thank
for your
you.
work.
Well, that is it for this episode. If you liked it, please tell your colleagues and let them know they can subscribe to MedAxiom HeartTalk on Apple, Google, or wherever they get their podcast. If you would like to send us a note directly or suggest a topic, email us at hearttalk@medaxiom.com. Thanks so much for listening.